I'm excited to welcome you to the Arthritis Foundation Advances in Arthritis Care webinar. So I'm going to go to my next slide. Tonight we are going to be talking about the history of arthritis care and how we've gotten to today, and maybe some exciting directions we're going to be moving to in the future. So a few housekeeping items first. You are all muted, and please use the Q&A function, which should be at the bottom of your screen, to type any questions for the presenters. We're going to have each of the three main presenters talk for about 15 minutes each, followed by a little bit of a quick discussion and Q&A at the very, very end. And today we will be talking about all kinds of arthritis, but a little bit of more of a focus on osteoarthritis in some of the presentations. And there will be, stay tuned to the end, because there will be a survey at the end. And don't forget, you will be able to see this webinar recording and a lot of our past recordings at youtube.com/arthritisfoundation or arthritis.org/webinars. So tonight's experts, I'm very, very honored to be included among this list. I am your moderator tonight. My name is Cheryl Crow. I'm an occupational therapist, and I founded my own patient education and support program called Arthritis Life. You might have seen me on social media trying to utilize the power of social media for patient education and empowerment. We also are so honored to have Dr. Yudi Kerbel. He is an orthopedic surgeon at First State Orthopedics. We're also going to hear from Dr. Kori Dewing, who is a registered nurse practitioner, and she is right near me here in the Seattle, Washington area, University of Washington Rheumatology Clinic at Northwest Outpatient Medical Center. And oh my gosh, I already see some questions coming in. That's great. Keep your Q&As coming. And then we also have Dr. Michelle McLeod from the Arthritis Foundation, who's the director of osteoarthritis clinical research programs. So here we go. The learning objectives are for you to simply be empowered through understanding the history of arthritis. I'm also a patient. I forgot to say that. I've had rheumatoid arthritis for 21 years. So I know, like many of you, I was put on really almost scary sounding medication at first, but understanding the history of the treatments and how targeted they are really helped me become more comfortable with using the medications, or in this case, we're also going to be talking about surgeries, maybe helping demystify that process and making it seem a little less scary to you and give you hope for the future, so you can understand, what is happening in arthritis care. What do we have to look forward to for the future? And we're also going to highlight some additional ways you can get involved and become more empowered on your journey. So I'm going to hand it over to our first speaker, Dr. Kori Dewing. And again, if you just came in, please feel free, welcome, and please feel free to use the Q&A function to identify any questions for Dr. Dewing.
Great. Thank you, Cheryl. So great. I'm really honored to be with you today. I've been working in the field of medicine for, gosh, I think it's 35 years now, actually, since high school, first starting as a certified nursing assistant and medical assistant, and then returning to school after my bachelor's degree in biology to study nursing. I received my master's in nursing in 2003, and that's when I started working as a nurse practitioner in rheumatology. Subsequently, I spent another 4 years in study and research to earn my doctorate in nursing practice in 2011 from the University of Washington. So in addition to diagnosing and managing patients with rheumatic disease, I also serve as faculty at the University of Washington School of Nursing, and I help to train the next generation of nurse practitioners. It really has been an exciting time to be practicing in rheumatology since I've been involved. Rheumatology is really, though, more than just a career to me. My mother also suffers from rheumatoid arthritis, and her condition started when she was in her 30s. So I have personal experience as well as professional experience. Let's go ahead and move to the next slide, Cheryl. So this slide is a little bit of a busy slide, but I'm going to talk through this as we talk about the history of rheumatic diseases. This is really a timeline. And if you take a quick look at it, you may see that there really have been 3 periods of breakthroughs in the field of rheumatology or arthritis. In the 19th century, arthritis conditions were defined, named, recognizing them all as distinctly different. Then when we moved to the 20th century, focus really shifted towards understanding the immunology and inflammatory natures of arthritis. Finally, in the most recent part of this timeline, the last 35 years or so ago, scientific evidence or advancements have led to the development of targeted therapies. These are monoclonal antibodies, and that's really been revolutionary for the management of rheumatic diseases. We call that period the biologic revolution. I'll talk more about that soon. So
Yeah,
we're going to take it. Go ahead, Cheryl.
when you say targeted therapies, do you mean medications?
Right. So targeting means that we've identified certain chemicals. These are cytokines or other substances in the body that drive the inflammatory process. And once those have been recognized, they developed these monoclonal antibodies. These are like 3D little puzzle pieces that fit specifically on these substances and block them and keep them from continuing their message to drive the inflammation in the body. It's a good question.
Oh, thank you. Just wanted to make sure everyone knew that that means the medications. Yeah, this is great.
Yeah. So let's take a look here at this timeline. When we take a look, we notice that it really goes back about 200 years, just over 200 years. But we do know that due to archaeologic evidence, these conditions really date back to ancient times. And back then, they believed that joint pain was caused by an imbalance in the four humors of the body. Treatment at that time was really limited to things like bloodletting or leeching and traditional Asian medicine techniques that are still used today, including acupuncture and cupping. It took until 1800, which is where this timeline starts, for modern medicine to differentiate what was later named rheumatoid arthritis from other types of arthritis like crystalline arthritis, that would be gout, or osteoarthritis. And still another 150 years later for the field of rheumatology to be established as a distinct specialty. That was really just a few decades before I started, amazingly. So though doctors had early forms of anti-inflammatory medication available to help patients with these conditions, these would be things like aspirin or salicylate. The discovery of cortisol, the natural form of corticosteroids or prednisone, methylprednisolone, those may sound familiar, was considered the first big scientific discovery in rheumatology. And when you look at this timeline, it was in 1950 that Doctors Kendall and Hench from the Mayo Clinic were awarded the Nobel Peace Prize for that discovery. It was really also around this time that what is now known as the Arthritis Foundation was formed to support patients and help provide funding for arthritis-related research, which was key at that time to driving some of these developments and some of these discoveries we realized later on. So with the discovery of corticosteroids, rheumatologists now had medicine that could help our patients with inflammatory conditions, almost overnight, though not without worrisome long-term side effects or health consequences. So we've talked about the initial understanding and definition of different types of arthritis in the 19th century. We've talked about the scientific discoveries in the mid-20th century, but really the most dramatic change over time in the field of rheumatology has been really quite recent during that biologic revolution I described before. Although the early use of what we call DMARDs, which are disease-modifying anti-rheumatic drugs, in the 1970s and 80s, including drugs like sulfasalazine or hydroxychloroquine, or I think you see methotrexate here on this screen, these marked a significant step forward in the treatment of inflammatory arthritis by slowing the progression of RA and improving long-term outcomes, but many of our patients still progressed with pain and disabling joint destruction. I've been told by some of my colleagues who've been in practice longer than me that back then, practicing rheumatology really could be heartbreaking, watching patients worsen over time without adequate tools to prevent joint destruction or disability. It was during this time in the late 20th century that major advances in diagnostics, some of the surgical procedures that we'll hear about later, and technologies set the scene for improved care for our patients. Breakthroughs in immunology, including the research funded by the Arthritis Foundation, led to the identification of the inflammatory chemicals we talked about earlier, and pathways responsible for driving rheumatic and rheumatologic disease. If you look at the timeline, in 1984, Doctors Milstein and Kohler were awarded the Nobel Peace Prize for developing monoclonal antibody technology that could block and inactivate these newly discovered inflammatory chemicals. So the first to be developed were the anti-TNF class of medications, and these are etanercept, adalimumab, and infliximab. These were the first that we had available, first biologics FDA approved for inflammatory arthritis patients back in 1998, so not very long ago. But these medications were really, truly game changers, truly disease altering. They not only helped to reduce pain, but were also shown to help stop disease in its progress. What was most exciting for those of us who were practicing at that time is that we had medications that if we started them early enough in disease, they could prevent that joint destruction and disability that seemed so impossible before. So I think back to this time, my mother actually was one of the first patients in the United States to be prescribed an anti-TNF medication. And I remember when that happened very well. It was very exciting. So really, in the years since, rheumatologists have been fortunate to see our medication toolbox expand with new classes of biologic medications being developed and approved. And when we talked about those, identifying those different cytokines or targets, these are what's noted here in this timeline. So these agents include ones that target IL-1, the co-stimulatory T cell pathway, B cells, IL-6, JAK, IL-17, type 1 interferon, and calcineurin. These biologic medications have really allowed us to change the way we treat inflammatory arthritis patients, no longer just reducing pain and accepting the inevitable joint pain and organ destruction and disability. So what started as 3 anti-TNF drugs in 1998 has now exploded to actually 18 different medications, biologic medications, in addition to our disease-modifying drugs that we have available for us to prescribe. Go ahead and go to the next slide, Cheryl.
That's really exciting. And just a quick question as we go along, because I know some people in the audience have rheumatoid arthritis, but some maybe have ankylosing spondylitis. Are these 18 medicines, are they all for all types of rheumatic disease, or are some of them for rheumatoid arthritis, some of them are for psoriatic, et cetera?
Right. So the ones listed here are for, why don't we go back to the last slide if I answer this question. The ones listed here, the biologics that I have listed, are ones that are approved for treating inflammatory arthritis. That could include rheumatoid arthritis or the spondyloarthropathy conditions like ankylosing spondylitis or psoriatic arthritis. It also includes the last two, which are indicated actually for lupus, which is another inflammatory condition, inflammatory arthritis or rheumatologic condition. So yeah, that's a good question.
That's great. Thank you. Oops,
Yeah,
I went too far. Sorry.
that's all right. We'll let you go back.
Happened?
I think you're going forward. So
Okay.
what you're going to see next is basically the timeline with a picture on top of it. There you are.
Yep.
And that picture really is a slide that shows the floor of posters at our annual scientific meeting that we have every year. Rheumatologists, over 10,000 rheumatologists and professionals come together and share the research that's happening in the last year. And this is just one of those mornings from one of those days at the conference a couple of years ago. Really, the amount of research being done in this field is truly incredible. And as I mentioned, it fills enormous convention center halls every year at our annual meeting. So this is where we learn about the newest science and discovery. So it's an exciting time. There's a lot happening. Next slide. Cheryl, do you want to go to the next slide? So we're going back to the timeline. The most recent important advance affecting our rheumatology practices and patients really is the development and use of what are called biosimilars. And some of you may have heard this term. Biosimilars are sometimes confused with generic medications. Biosimilars are, as the name implies, highly similar biologic copies of existing monoclonal antibody therapies already available. So like generic therapies, these medicines have been developed with the hope of reducing the cost of the treatment and helping to open up access to therapy. The first monoclonal biosimilar was FDA approved just 7 years ago, and we now have over 16 currently approved and being used in the US in rheumatology. So that's an enormous increase. Hopefully over time, this will help to reduce the cost of treatment for our patients. So up until this point, I've been focusing mostly on inflammatory arthritis conditions and treatments and how that's come about in our timeline, as these are the conditions for which the biologics have been approved and developed. However, I will also say that there have been tremendous developments in osteoarthritis in the last 30 years as researchers are better understanding how the mechanical forces affect the immune and central nervous systems in osteoarthritis. So we've been talking about development of disease-modifying osteoarthritis drugs, which is different than disease-modifying anti-rheumatic drugs. So DMODs, or disease-modifying osteoarthritis drugs, we've been talking about them for as long as I've been in rheumatology, fully expecting something to, be broken through, being some treatment to come available to us to be able to use. We better understand who's at risk for developing OA. We better understand the role of weight loss and exercise, and we now have advanced surgical interventions to treat OA. Yet, despite these advancements, we still don't fully, truly understand the underlying complexities of what's going on in osteoarthritis, and we still don't have that elusive D-mode or a cure. So when I look back over the last 200 years at the discoveries and historical developments and achievements, I truly do remain optimistic about where we're headed in the future for our patients with all kinds of arthritis. So I'm going to go ahead and stop there, Cheryl.
Great. Thank you so much.
You're welcome.
That was very helpful. And we do have a lot of questions already in the Q&A. Keep them coming. Some of us have been already responding to people individually, and some we're going to also address live. So that's really, really helpful to understand, the history of these treatments. And we're going to hand it over now to Dr. Yudi Kerbel to talk a lot more about the surgical interventions. Dr. Dewing talked about the medications. Now we're going to get into how do we actually, what's the history of this? It's going to be a little gnarly at times. So those of you, some of the pictures, actually they're not too bad, but there's going to be some pictures of the old-fashioned surgery, which makes me glad to live in 2024, right? Same, hopefully, with you, Dr. Kerbel. Okay, I'll give it to you.
Absolutely, yeah. I tried not to include anything too gnarly. Because I think that's one of the problems is I have a lot of patients who come to me and they've already let their arthritis get really bad because they were so scared to come talk to the doctor because they were afraid of what surgery entails and what it means. And so it kind of kept them away from seeing someone about their musculoskeletal health. And so my goal with this presentation tonight is just kind of empower you with knowledge about what the options are out there. Just so you understand a little bit more about if you get to the point where surgery could help you, what that entails, what the recovery looks like, and hopefully, if it is the right option for you, you'll feel a little bit better about the process after going through this. So we can go to the next slide. So first of all, let's talk about what is joint replacement. So I think a lot of people, joint replacement is kind of a misnomer. I think we picked the wrong name for it because a lot of people think it's like the photos in the top right here. They think that you cut above the joint, below the joint, you chop the whole biology out and you put in a fake joint. Really, that's not how it is at all. What we should call it is joint resurfacing because that's what we're doing. So if you look at the middle picture on the right, you can see, so there's a knee over there, which looks very arthritic, and that's what osteoarthritis looks like. Rheumatoid looks a little bit different, but it's the same sort of general idea, is that your bones the joint surfaces are covered in this smooth white cartilage material, which is essentially more, has lower friction than ice on ice. So it glides beautifully over one another, and you have this amazing motion that carries you around and makes all your movements. Unfortunately, as degeneration progresses, whether that's from osteoarthritis or rheumatoid arthritis or psoriatic arthritis or any manner of different arthritic processes, those arthritic processes eat into that cartilage. And so you now, instead of having the smooth gliding surface one on another, you have what's more like sort of a pothole road where, a car's driving over it and it's all bumpy because there's potholes in there. So the goal with surgery is to resurface those roughened surfaces and to make it back into a nice smooth surface that glides on another. So you can see on the photo on the right, you're not cutting out the whole joint, you're really just resurfacing the tops of the bone. And the whole idea is to return function and motion and get you back to doing everything that you love. So let's go to the next slide. So let's talk about, just to give some context, the history of hip replacement. So if you look on the top right, you can see an ivory hip. And the original pioneers who thought about the idea of joint replacement, they had a great idea. It didn't work out in practice, but the idea was, what if we can take these surfaces that are worn out and we can replace them with something that is smooth and could recreate that gliding motion, and at the same time that the body will react well to. I guess ivory was a much more prevalent material back then, and so they thought that would be an ideal material. It didn't pan out that way, but that's kind of where it all started, right? In the late 1800s. Then we progressed a little bit beyond that, and in London, there was a surgeon called Philip Wiles. He performed a successful total hip replacement using a stainless steel joint in 1938. And if you look in the middle row of pictures on the left, that's what his one looked like. Again, smart idea, definitely took it further, but what didn't really pan out in practice because it relied on being plated to the side of the bone, which wasn't a durable construct. Where it really took a leap forward was in the 1960s with a surgeon called Sir John Charnley in England. He's called the father of modern hip replacement. He came up with this idea of low friction arthroplasty, which is that photo right in the middle. It's a metal stem, it's a polythene cup, and he actually cemented it into the bone. He came up with this acrylic cement, which is actually really a grout. Cement is a misnomer, to really get the components to stay there in the patient. And if you look in the middle row on the right, that's kind of what his surgery looked like. What's incredible is there are actually a few people in the world still walking around with one of these implants in them, and the durability of those implants has actually been unbelievable. But there were a lot of things about that surgery that still weren't so great. If you see in the photo, there's all those wires around the outside of the bone because they didn't realize that you can get down to the hip with a less invasive method. And so they actually sort of cut off part of the bone and moved it out the way and then put it back at the end. We've come a little bit of a way since then. And so at the bottom is kind of how a modern hip replacement looks. So on the left, you see what the x-ray looks like. And on the right, you can see what the parts look like that we put in. And so in the United States, it varies a little bit from country to country, but in the United States, it's typically done without bone cement. It's a titanium stem, a titanium socket. The stem goes down the middle of the bone, of the femur, the thigh bone. The socket goes into your native acetabulum, which is your native socket. And in between, you have usually a ceramic head and a plastic, highly cross-linked polyethylene surface. And now you have that smooth gliding motion. And over time, we've refined these techniques and these materials to the point where now total hip is really an amazing, durable operation that gives people their lives back. So that's kind of where we were to where we are now with total hips. Next slide. Now we can talk about total knees. Knees are a little bit different. A hip is a ball and socket joint. Ball and socket, pretty simple. A knee is very complex because there's all these different ligaments working in different ways, and there's multiple surfaces, and it's a really difficult joint to replace. And that's kind of why knee replacement has always had traditionally a little bit less of a success rate than hip replacement, because it's much more complex, even though nowadays we're working on new innovations to really make knee replacements better and better. So again, if you look at the top left, you can see it's actually the same doctor who came up with those ivory hips, Dr. Themistocles Gluck in Germany, again in the 1890s. He came up with this idea of putting a metal, I think he did an ivory hinge as well, and then he did some metal hinges. Again, super clever concept, brilliant innovation, didn't really pan out in practice. So we sort of came along for a little while, and then the 1970s was another huge breakthrough, and that was when Dr. John Insull in New York City, he developed what's called the total condylar knee, and those are those photos in the middle, which is a bit more of a concept of resurfacing the femur with a metal component, getting in this case, he had a plastic component in the tibia. Nowadays, we use metal, and he cemented those in place, and that was a huge step forward in knee replacement. Today, we're taking that even further. So the photos on the bottom kind of show you what we're working with today, and we usually have a titanium tibial component, so that's the one on the bottom, into the shin bone, and then we have a cobalt chrome, which is another type of metal that goes on the femur, and in between usually a piece of plastic that's highly cross-linked polyethylene. And so again, resurfacing the bone, creating the surface that glides on one another. And as we get more and more knowledge of how the knee works, we're refining the way that we put these in, how we're balancing it, what we're using to put it in, and getting better and better results for our patients, getting them back to the activities that they love. Next slide.
I love it. I just really appreciate that you're tying this all back to bringing people back to the doing the things that they love. That is the goal.
100%. And that's
Yeah.
always what I tell my patients, because a lot of people come in and they're like, so what do the x-rays say? Do I need a knee
Yeah.
replacement? You don't ever need a knee replacement. No one dies from a painful knee or a painful hip. What
Mhm.
this is about is quality of life. And so I always tell my patients, it's not, I don't treat your x-rays, I treat you. It doesn't matter if someone has a x-ray with a lot of arthritis and they have no pain, I don't care.
Yeah.
I want to alleviate pain and get people back to what they want to do in their life. So if you're doing well, and a surgeon tells you you should get it replaced, I would say maybe talk to someone else as well, because the whole goal here is to alleviate pain and get people back to living a life full of vitality and quality and doing the things that they enjoy. And so that's really important when you're keeping this in mind. And I know a lot of questions in the Q&A are like, what are the options for me? What can I do? It's hard to answer. And I saw some pushback saying like, well, all you're telling me is talk to your doctor. But the reason is because everybody's different, right? For some
Yeah.
people, medicine works amazing. For some people, it doesn't. Some people go to alternative therapies and it's a lifesaver for them. Other people not. So it really it depends on you. And it's really important to individualize your treatment. When patients come to me, I don't do the same thing for any one patient because everybody's got a different set of circumstances. Everybody responds to something differently. And that's the whole thing we're trying to empower you with in this webinar, is understanding that there's more and more options out there now. And the goal for you as a patient is try different things, see what works for you. If that other stuff doesn't work, then surgery is a last resort that we have that works well in those patients. But it's important to note that the whole goal here is getting you back to a life that you love. Next slide.
That's beautiful. I'm so glad this is being recorded. Preach. I'm speaking for the audience now. Preach. Okay, what do you actually do during
So
surgery?
yeah, this is without the gory details, but it just
Yeah.
people want to know, so what do you do? Do you cut it out? I just want to give you sort of the broad strokes, just so you understand what's actually entailed. Because again, I think what scares a lot of people is they don't even understand they think I'm sort of roughly cutting them open and just ripping their stuff out. Nothing could be further from the truth. The whole goal, especially with hopefully a good surgeon who really thinks about you and tries to personalize the surgery to you, is to look at you and your native anatomy and what you're trying to get back to and come up with a personalized solution to make you feel better and get you back to that life that you love. So in a knee replacement, the basic idea is you make an incision along the front of the knee. I put a photo over there in the front. The classic knee incision is sort of this huge thing that sort of goes halfway up your thigh, halfway down your shin. My personal philosophy is I try and avoid that. Not every surgeon agrees with me. My personal philosophy is the less soft tissue damage we can do, the more of your native anatomy I can preserve, the easier it's going to be for you to recover and the faster we're going to get you back to the things that you love. So that sort of shows you the difference between a more minimally invasive incision like I do or traditional incision. Both of them work. Both of them are fine. It's just a surgeon thing and depending on what you want. Then we go in, we open up the knee and we look, and right away when every surgery, when I open it up and I look at that arthritis, it still amazes me. I always say, wow, this looks so painful. I can't believe this patient was struggling with these surfaces rubbing on one another. So what we then do is we resurface. We just take out a small sliver of bone where that worn away surface is. In a total knee, we take out one of your cruciate ligaments. Some people take out two, your ACL. It doesn't matter with a total knee, but we leave the other ligaments. People think we cut out your MCL, your LCL. We leave most of them. We try leave as much as we can. And then we just resurface the joint with metal. So if you look in those photos on the right, you can see on the one on the left, even to someone who's not looking at x-rays, you can see that looks rough. It looks not smooth. When you look at the one next to it, you can see that now we've resurfaced the knee back to metal. We've got plastic piece in between there, which doesn't show up on the x-ray. And now you have a smooth surface that glides again. And so when patients wake up from surgery, they tell me, okay, it hurts that I had surgery, but that rough bone on bone feeling is gone. And that's what makes me happy when patients say that. And then in some cases, we also will resurface underneath the patella. And I put a picture at the bottom there just to kind of show you, we don't take out, people think you take out the kneecap. You don't take out the kneecap. Again, you just smooth out the back of it. You put a plastic button on, and that can now glide on the knee. So that's the basics of a knee replacement. Let's go to the next slide and we'll talk about a hip. Oh, sorry, one more thing. One option that people don't realize, everyone thinks you have to get a total knee, and a lot of surgeons, I think, push people to a total knee, but you have to understand, not everyone needs a whole knee replacement. So in a lot of patients, you might, well, not a lot, I would say it's a small percentage of patients, but not no one, probably 20 to 30% of people only have arthritis in a very small part of their knee. So if that's the case, you actually can get a partial knee replacement. And I put these x-rays to show you the difference. If you look on the left, you can see a total knee. In the middle, you can see a partial knee replacement, and on the right is another kind of partial called a patellofemoral, which is a partial that just focuses on the kneecap. And as you can appreciate from those x-rays, much less damage done to the knee, much less surgery required. I'm a huge fan of that because I believe in it. I've seen patients do amazing. And again, my philosophy is the less damage I can do to a patient's knee, the less I can disrupt their native anatomy, the better they're going to feel, the easier it's going to be for them to recover. So that's one thing I wanted to empower you with. You may not be a candidate based on your arthritis, but this is something when you're going to a surgeon and you're talking to them, ask them, am I a candidate for a partial knee? You may not be. The surgeon may not be someone who does partial knees, but it's worth at least exploring that option and seeing if it's right for you, because if it is, your recovery could be much easier and you could get back to even more things that you enjoy. Next slide. Now a hip replacement. Hip replacement's a little bit different. And in hip replacement now, the whole controversy is how you approach it. You can go from the front, from the side, from the back. There's a lot of marketing about it. I do several of these approaches, so I am a little bit less biased, I feel, than other surgeons because I like them all. The truth is, it doesn't matter. What matters is a good hip from a good surgeon. And what you basically do with a hip replacement is you go in and you cut out sort of the ball and socket. You cut out the ball portion so that that was the arthritic surface. You cut that out the way. The socket that's behind, you smooth that out with what we call a reamer, and you put a metal socket in place. And then you put a metal stem that goes down the inside of the bone, fits to the patient's native anatomy. And then on the end of that, you have a ceramic ball and again, a plastic liner inside the shell. If you look on the right in the middle row, you can see an x-ray of what that looks like. So again, nothing too crazy. Most of the stuff is still there. You're not chopping out whole, big areas of bone. You're just taking out the arthritic parts and creating a new smooth surface that allows patients to feel better. And then there's another option called hip resurfacing, with only not that many surgeons in the country do. Again, I do it because I like any option that preserves more native anatomy. And that's the picture in the top right, where you can see that instead of cutting out the whole femoral neck, you just, again, you sort of just resurface the end of the bone and then put that with a cup. And that's just another option, again, that is right for some people that I just wanted to put out there to empower you with knowledge. Next slide. And so here again, x-rays just to show you the difference. Total hip on the left, that's by far the most common one. Hip resurfacing in the middle. Hip resurfacing is not an option for most people, although it is becoming more of an option with some new technologies that are coming out, just changing the materials. And then on the right is not something that is done electively, but I just wanted to, again, to empower you with knowledge, because you might have relatives who fell and broke their hip and they got a half hip replacement, which is a hemiarthroplasty. And all that means is you don't put the socket part in, you just do the femoral stem and you put a big head on it. I just wanted to put that out there just so you know now you've seen it. If that ever is helpful to you, at least you have that knowledge of what that means. Next slide. And then now a quick thing. Again, people ask me after surgery, a lot of people think you're bedbound, you can't walk for days, weeks, months. Couldn't be further from the truth. So when you talk about post-op restrictions, you actually have very few. My goal as a surgeon, when I operate on a patient, I want them up and moving right away. And in fact, I do a lot of my surgeries now, sending patients home the same day from the hospital. And 2 hours after surgery, they're already up and walking with physical therapy, doing the stairs. It's not this crazy limiting thing that people think. They think they're going to be bedbound. It's never going to be the same. It really doesn't work that way. Nowadays, we've come so far with the pain control, with the anesthesia that we use, with the materials that we use. And so, again, there's no weight-bearing restrictions. We want you to get up and move. Again, just to reemphasize, the whole point of doing all of this is to bring you back to your vitality, to give you your life back, to let you get back to doing the things that you love. So, sometimes there's a few little things just while it's healing, like if you do a hip replacement from the back, some surgeons will tell you not to flex your hip. Sometimes some surgeons want that, some don't. Not a big deal. Does not impact most patients. You have to give your incision a few weeks to recover. I put, and most surgeons now put waterproof dressings on our patients. You can shower right away. You can't soak it in a tub or a hot tub or go swimming for a few weeks, but you can be showering. You can be up. You can be cleaning yourself. It's not like you have to take sponge baths. It's much easier than people realize. Same thing with driving. People think they're not going to drive for months. I let my patients drive 2 to 3 weeks after surgery when they're ready, and as soon as they're off any pain meds and they're feeling ready, they can get back to it. And then if you want to get back to high impact activities, you can with joint replacement. Some people think that I'll never be able to play sports again. again, my whole goal is to get you back to doing what you love. So if that's what's meaningful to you, if that what gives your life quality, then do it. Just speak with your surgeon about it, see what's the right option for you. And then down the road, things like high impact running, I let my patients get back to all of that if they want.
That's
Next slide.
incredible. I can attest my mom just had her hip replaced a couple months ago, and it's been amazing. I was trained as an occupational therapist 20 years ago, and I mean, sorry, 10 years ago, just in the 10 years since I was trained. It's
Oh yeah,
amazing. We used to have the
unbelievable.
patients stay for like a week. Now it's just like go home, run around. It's amazing.
Unbelievable. Yeah, I literally have my patients, I mean, and we're not even, I'm not talking about like 45-year-old people. I had an 83-year-old lady who come in yesterday. I did a partial knee replacement on her. She was back home last night in her own home, sleeping in her own bed. I called her today to see how she's doing. She's doing great. So there's
Amazing.
just, it's what's amazing about this is I think a lot of people see surgery as this like restrictive, terrible thing. But what the thing is, it's absolutely, you exhaust all the other options beforehand. But if you get to that point, it's an amazing option that we're very blessed to have now to get you back to your life that we didn't have a few decades ago. And that's what I'm passionate about, is really getting people back to their quality of life.
I love it.
And then just a few things, because I get a lot of these questions. I just wanted to touch on some stuff because people are going to be like, what about this? What about that? So a couple things. Robotics is obviously a huge thing in joint replacement now. I will say there has been no conclusive evidence that robotics makes a huge difference in patient outcomes. That being said, it's an amazing new technology that's coming out. What really excites me is the augmented reality stuff that's coming out. If you look in the photo in the top right, there's new technology coming out now where you actually wear goggles as a surgeon during the case, and it imprints a 3D image of the patient's anatomy on their body and actually shows you in space where to position your hands during surgery. You still need a good surgeon who knows how to do the surgery, but these are more and more tools that we're having coming out to help us as surgeons get a result that's more personalized to you, closer to who you are, which ultimately hopefully gets you back to the stuff that you love. There's some new stuff with bearing surfaces, whether the quality, the ceramic that I spoke about in the past, we were using metal, that caused some problems. Now we have ceramic. One company even has a fancy ceramicized metal that they create that supposedly lasts forever. And it's just exciting because there's continued innovation. We're not sitting still. We're trying to come up with new stuff that makes these joint replacements last longer and wear out less. Outpatient joint replacement is a huge thing. I trained my fellowship in the place that did the first outpatient joint replacement in the world. They now send probably 90% of their patients home the same day. It's a huge quality of life thing. It's so much better to be home in your bed at night and not in the hospital. And it's amazing that we've advanced our pain control and our surgery to that point. We have tools to help us with treating infection now. We have next generation sequencing that can look at the genetic DNA of the bacteria and help us pick exactly the right antibiotic to treat it if, God forbid, an infection happens, which, by the way, is less than 1% of the time. And then we have all these amazing new pain control options that are bring us, which is also really revolutionized arthroplasty. So in summary, and I think a lot of people are really scared of it, and they think surgeons, we all just can't wait to jump in there and cut them. I try everything I can to not do surgery first. I try everything I can to give the patient their life back first with other things like we've mentioned tonight, alternative therapies, medications, injections, sometimes just lifestyle management things. If that doesn't work and you're in that boat, we now have amazing options for you to give you your life back with these incredible surgeries that we do. We can help you get through them, we can help you recover, and we can get you back to doing all of the things that you love. So my end statement is, don't be scared to just go talk to a doctor about it. Everyone thinks that you're going to walk in and the doctor's going to say, you have to get a knee replacement. Most of the time it won't be that. And you'll walk out feeling so much better about what's going on with you and the options that you have. Just start that conversation, meet your doctor or your other healthcare professional, and just get that conversation going, because ultimately the goal is getting you back to what you love doing.
Love it. Well, absolutely love it. Thank you so much. And there was a lot of great questions for you. We're going to hold the questions till the end just in case they happen to get answered by our next presenter. But, there's questions about surgery in the hand and what about the ankle and your shoulders. Let's cover all the body parts. And so we will get to some of those. Please don't think we're not looking at your questions. But thank you so much Dr. Kerbel, it's really, you've honestly made me feel less scared about surgery, which I don't have any in my near future because my medications are working. But other people in the chat or the Q&A have been saying that they feel more hopeful. So I really appreciate that. And I love this picture of your family. Don't forget, surgeons are people too.
And if anyone has any questions and wants to reach out to me, I'm happy to answer.
Thank you so much. All right. Next up, we have Dr. Michelle McLeod, who is the director and of OA Clinical. OA is short for osteoarthritis. For those who might be newly diagnosed, I always try to define the terms. Clinical research programs. I'm excited to hand it over to you.
Yeah, thank you for the introduction, and thanks everyone for being here. I'll do my best to answer some questions that have come into the chat related to this, and you know, this will be followed by a Q&A session as well, so we can certainly continue to the discussion. So we can go ahead to the next slide. And as we have heard, or as some people have asked questions about in the chat, you know, what's going to be covered here, there are certainly a lot of different disease areas that fall under that umbrella term of arthritis, but I'm going to be focusing on rheumatoid arthritis and osteoarthritis, which are two of the disease areas that are priorities for research being supported by the science team at the Arthritis Foundation. You can go to the next slide, please. And so I think it's important to give just a little bit of context. I know a lot of you that are on the call here tonight listening to the webinar are living with rheumatoid arthritis. And so, you know, if anything, this is just, I think hearing things in repetition is a good thing. And also maybe just a reminder that, you know, what you're going through, you're not going through alone. So, you know, when we're talking about rheumatoid arthritis, specifically in adults, that it's an autoimmune and inflammatory disease. And so what does that mean? You know, autoimmune means that for some reason, and in RA, we don't fully understand, but our immune system is attacking healthy cells in the body. There are over 1 million people in the United States that are living with rheumatoid arthritis, and some risk factors for developing RA. We know that women are twice as likely to have rheumatoid arthritis than men, and of people who are diagnosed with RA, 70% of those people are women. So in addition to some of the risk factors for developing RA are age, typically the onset may be a little bit later in life, not always, but later in life. Again, being a woman is a risk factor, having a history of being a smoker or being exposed to maybe secondhand smoke or other environmental things that trigger RA. History of live births. So women out there, if you have never given birth to a child, that actually puts you at risk for developing rheumatoid arthritis. There's a link there. Having obesity, and then also inheriting gene traits that are linked to RA are some of the risk factors for RA. It's common in multiple joints. There have been a lot of questions in the chat this evening about hand, about all different areas, but commonly RA presents in the hands and the feet first. And the challenge here is, you know, as many of you have spoken to, is that there is no cure. There are a lot of treatments available to help manage symptoms and to slow the progression and maybe slow down the change in the shape and the deformity that we often associate with RA, but there is no cure. And the challenge is that RA is a heterogeneous disease, meaning that it presents in a lot of different ways in a lot of different people, and not everyone responds to those treatments. So we know that the burden is that, you know, it impedes function. You have more fatigue, you have more interactions with healthcare providers, which could be a financial burden. And you also know that people with RA tend to have more comorbidities. So they develop things like cardiovascular disease. You're more susceptible to infection. People with RA may have more depression or may have mental health related issues as a result of living with RA, and an overall decreased quality of life. So this is certainly an area that, while there are many treatments available, there are still some critical needs that need to be addressed. Next slide, please. And so some of these needs and the expansion for therapies of RA, the RA program at the Arthritis Foundation really launched just a couple of years ago, or a few years ago, back in 2021. And they've identified some priorities of areas to support research. And in the past few years, I'm going to briefly just touch on some areas of research that are currently underway. So, right now, while I might not have the answer that maybe a lot of you are looking for, I'm here to try to reassure you that it is getting attention, and there are scientists and clinicians out there who are actively looking for these answers to help make a difference for those of you living with RA. And so there's this idea of personalized medicine, which Dr. Kerbel spoke to a little bit earlier when talking about some of the advances in surgical approaches. But there is an unmet need. So, as I mentioned, there are a lot of treatments that are available for RA, but we know that some people respond really well to these treatments, but that there are a lot of people who don't respond to these treatments. And so why is this happening, or why don't people respond very well? And so it's estimated that there are about 20% of people who are diagnosed with RA, will start their regimented treatments, but about 20% of those people don't respond well. And so this is called refractory or difficult to treat RA, which is one of the priorities that's been identified as an unmet need that needs to be addressed. And so, this is certainly important for us to better understand what are some of those biological mechanisms that happen in responders, and so that we can look at people who aren't responding well and try to optimize these different treatment options and getting the right therapy into the hands of the right people who will potentially respond, getting them to them earlier, because we know that early intervention makes a difference down the road. And so other areas under this idea of personalized medicine is to try to identify biomarkers and other therapeutic targets. And so what we mean by that, a biomarker is something that we can measure in a person or an organism. That can even be things like pulse, blood pressure. Those are biomarkers in areas like cardiovascular disease, levels of cholesterol, but something that we can measure that indicates some sort of phenomenon, either normal or abnormal, that tells us about a disease state. So if we can continue to identify what specific biomarkers related to RA might tell us about someone's ability to respond to a specific treatment, to again optimize getting the right treatment into the hands of the right person, and to be able to specifically target our treatments. Another area that is currently being studied are immunological signals in blood tests. So essentially what we're looking for is, do a simple blood test and be able to look at what's in the blood, what type of proteins and other signals might tell us about our ability to predict who might go on to develop RA, to again be able to intervene earlier. So another way to think of this is, thinking about the concept of someone who's pre-diabetic. Excuse me. So, we can look at blood tests, look and see what's their elevator, what's their fasting blood sugar levels look like. And that can often, give us an indication that this person may be at risk for going on to develop full-blown diabetes. And so we know that we can intervene earlier with different things to prevent that person from going on to develop that disease. So it's the same principle here, but specific to RA. So there's some really great researchers out there who are starting to look for what signals might be present in the blood to help us predict who will go on to develop RA. And then also microbiome function in the gut. So this is another, we hear about this a little bit more in all areas of research, but just the role of our gut microbiome and how it's linked to our health. And I think it was actually mentioned earlier, methotrexate is the gold standard for trying to address some of the inflammation that's associated with RA. But again, maybe in the individuals who don't respond well to methotrexate, what if we can take a look at what's happening with their gut microbiome? Are we able to change it to then make it a more optimal environment for someone to respond a little bit better to some of these anti-inflammatories, such as methotrexate, or other therapeutics that are available, to see if again, maybe we need to create a better environment for some of these things to happen. So that's just a brief summary of some of the expansion of therapies for rheumatoid arthritis. And on the next slide, I'll shift gears a little bit and talk a little bit more about what's happening in the osteoarthritis space, which I'm a little bit more involved in. So again, osteoarthritis, the most common form of arthritis. There's over 32 million people in the United States who are living with OA right now. It used to be thought of as like a wear and tear disease that was associated with aging, and we know that that's not an accurate way to think about OA. Anyone can get OA, and it's a disease of the entire joint. It's not just bone on bone, but there's other tissue there. So it's a disease that includes the tendons, the ligaments, the fat pads. And so all of those things need to be addressed when thinking about joint health. You can click next. And so who gets OA? We see some similarities here with RA, but it's primarily older individuals. Although it's not a wear and tear, it's not necessarily aging, but at this point with individuals who have primary OA, it is typically older individuals or people older than 45. Most of those individuals are women. Next. And we know that there are we've started to identify some risk factors of who is at an increased risk for developing OA. Again, women, people with obesity. Another specific risk factor for accelerated development of OA is people with a history of joint injury. Next slide.
Yeah, and someone just asked in the chat if you can have both OA and RA. I am a living example of that you can, yes, have both.
Yes.
Yeah.
Yes, when I first joined the Arthritis Foundation, I was privileged to have a few conversations with some of our patient volunteers who are really engaged with the Arthritis Foundation, and a lot of them for a long time were living with both, and it took some time to get both of those diagnoses. But yes, it is common that people will have multiple forms of arthritis, definitely.
Yeah. Thanks.
Yeah. So the need, and again, similar to RA, there is no cure for OA, but there are also currently no disease-modifying treatments. There really just are not a lot of options available for OA. And I heard that frustration. I read that frustration in the chat. And I'm here to tell you that we hear you. There are a lot of people who recognize that this is a concern, and in studying OA and getting therapies developed, the science is just, it's really behind compared to other areas of research. Some of that is that, there's not as much money for funding for OA research as there are in other disease areas. I think some of that, comes from, I think even Dr. Kerbel mentioned it earlier, but people aren't necessarily dying from osteoarthritis, right? But they are living with disability. They are living with a decreased quality of life. And the current recommendations for treatment are focused around symptom management, so controlling pain, modifying load and activity through diet and exercise, and physical activity is encouraged. And I put this in italics, and I put stars around this because, I hear you. For some people, getting started with physical activity is really hard. It can be intimidating. And maybe you're one of those people who, you're in pain. So physical activity is painful. And so for some people, physical activity is just really not feasible. But currently, that is the best recommendation for osteoarthritis. Next slide. So where's the science with OA currently? There have been a lot of animal studies in the area of OA that we're currently leaning on to really kind of guide us in where the science needs to go next. So what they do in animal studies is they'll test some treatments in animals that have a similar disease, or they use models like inducing an injury in an animal and then testing different interventions to see, well, can we prevent the onset of OA after having an injury? And those models do help us to understand how the disease progresses. And so, we've gotten groups of experts and of clinicians, of rheumatologists, of scientists together to have these discussions and say, can we start to try to apply some of these models to human studies? Next slide, please. And so I want to talk about two studies that are in the space of preventing osteoarthritis. So again, not necessarily what most of you on the call with OA are looking for, because you've already been diagnosed with OA, but I think that there's still some hope that's presented with the knowledge that we can gain from these studies. So again, the challenge with studying primary OA is that by the time someone is diagnosed with OA, typically that disease is so far advanced that the options for treating it are limited. And so that's where you hear a lot of those conversations of, talk with your doctor, talk with your primary care provider, see what options are available to you. And then as far as clinical trials, which is what's needed, again, to get that FDA approval for either drug development or different interventions, the follow-up period is typically too short of a time frame for OA to develop during a study. So this is where that animal study really comes in nicely in looking at post-traumatic osteoarthritis as a potential area to intervene and study our ability to prevent the onset of osteoarthritis. So this study is called Picasso. They just launched this. They're just now starting to recruit participants for this study. But Picasso stands for Preventing Injured Knees from Osteoarthritis Severity Outcomes. And the picture of the two gentlemen here are Dr. Morgan Jones and Dr. Cale Jacobs, both at Mass General Brigham in Boston. And so this is a multi-center site where we will be looking at the effects of the drug metformin, which is a type 2 diabetes drug, to see if it will help to prevent knee osteoarthritis in patients who are at risk for developing OA. Next slide. So the question with Picasso, again, is can metformin prevent the development of knee OA after injury? So how did we decide on metformin? You heard me say it's a type 2 diabetes drug. Why are we using it to study OA? So there are some advantages to metformin. Number one, it is a safe and affordable off-patent drug, meaning it's off of its markets. It can be produced as a generic drug. It's got an excellent safety profile, meaning that if someone who doesn't have type 2 diabetes takes metformin, it's not going to alter their blood sugar. So it's safe to take and it's very affordable. Why we're interested in metformin is that it may have the ability to decrease inflammation and therefore pain. And in some of the animal studies where it's been used, it may actually preserve cartilage and help to slow down degradation. So we're interested to see, will this work after someone has had a knee injury who doesn't already have OA? So in this study, we'll be recruiting adults who are at least 18 years and older and who have torn their ACL in the past 6 months and will be scheduled for surgery. And again, this is a unique study because it is a prevention trial following joint injury. It's the first of its kind. Next slide, please. So what happens during the Picasso trial? You can see on the map, the states in green are where the sites are located that will be recruiting participants to participate. And so participants will be randomized into one of two groups. So they'll be randomized to a group that either receives metformin or they will receive a placebo drug. They'll take some pictures of their knee on X-ray or on MRI. That's got a lot of really great definition that allows them to see what's happening in the cartilage very well. They'll take some surveys related to how much pain they're having and how they feel. They will have their ACL reconstruction and have regular PT. And then they'll do some additional assessments like observing how well these people move and continue to ask them about how they're feeling. They'll take some follow-up pictures and some follow-up assessments about their strength and how they're moving over a 2-year period. So at the end of that 2-year period, we'll be able to go back and look and see how did the participants on metformin perform? How did they feel? How did the structure of their knee change compared to those who were on the placebo? Slide. So why is this important? So this is really kind of a pathway to the rest of OA. So if the study is successful, it will allow surgeons to start prescribing metformin right away. So again, I said the advantage of metformin is that it's cheap, it's safe, it's available, it's off patent. So we could potentially start to see it being used for this purpose immediately. And then the other outcomes associated with the study may allow us again to start to develop or identify some early diagnostics similar to some of the previous discussion, but allow us to try to find out who is potentially at risk and who is likely to go on to develop OA to be able to intervene earlier. And this will also give us some alternative approaches or other areas of work in the effort to find treatments for OA. Next slide, please. Another study that I wanted to introduce to everyone tonight is called the Osteoarthritis Prevention Study, or TOPS. And so this is led under the direction of Dr. Steve Messier at Wake Forest University in North Carolina. And he's also got colleagues. So this is another multi-site study where the other sites are UNC Chapel Hill. We've got a group out of Boston contributing, and then also the University of Sydney in Australia. Next slide. So a few slides back, I talked about some of the risk factors for developing osteoarthritis. And two of those things were being a woman and also having obesity. And Dr. Messier and his team have done a really great job over the past several years of demonstrating that intense weight loss and exercise can treat people who already have OA and help to treat and manage their symptoms. So again, the question is coming back to, well, what if we introduce this intervention earlier before someone has an OA? If they participate and they lose weight and they continue to exercise before they have OA, does that keep them from developing OA to begin with? So the TOP study related to some of those risk factors and what they have shown that they can do with weight loss and exercise. We'll be looking to enroll women who are at least 50 years and older and who have obesity but do not have an OA diagnosis and currently have little to no pain. Next slide, please. And so what the participants will do in this study, they'll be randomized again into one of two groups. They'll either be put into a group that receives diet and exercise. So for the first year is a weight loss phase, and then years 2 through 4, excuse me, this is a 4-year study, years 2 through 4 will be a weight loss maintenance phase. The other group is an attention control group where they will meet quarterly for group sessions, and then will also receive monthly text messages and newsletters from the study team over that period of 4 years. Everyone will be followed again to observe and see who goes on to develop knee OA and who does not. Next slide. And so the last point that I wanted to touch on before wrapping this up and getting to the Q&A, since we have so many questions, is advancing women's health research. So again, not to leave the men out of the conversation, but one thing that we are certain of that we know is that women are at an increased risk for developing arthritis, whether it's rheumatoid arthritis, whether it's osteoarthritis. And unfortunately, over the years, women have been underrepresented in clinical trials in medicine. And so the White House recently announced an initiative on women's health research. This is a new $12 billion initiative. And the goal is to be able to fundamentally change how we are including women's health and how we are addressing women's health research in the United States. You know, it's not sufficient enough to take a lot of the medical research that has been done, you know, on men and apply it to women. It's not an appropriate match. And so this will prioritize women's health research across the lifespan, starting the conversation of identifying where are the gaps, how do we fill the gaps, what are our priorities in women's health research across the lifespan. And this includes autoimmune diseases. Autoimmune diseases such as RA have been called out specifically. So we are thrilled at the Arthritis Foundation that this is receiving additional attention. And then I will wrap by bringing it to the next slide. If you would like to learn more about how the Arthritis Foundation is going to be involved in advancing women's health research, there's a QR code. You can scan that with the camera app on your phone. It will take you to the Arthritis Foundation website that has a link to the letter that's signed by the Arthritis Foundation CEO, Steve Taylor, addressed to the President and the First Lady of the United States, and our support of women's health research. And so I will leave it there.
That's so exciting. Thank you so much. And I'm going to now stop projecting the slides so we have a chance to just see each other a little bit. And I'm going to start the live Q&A session where we're going to take some of your submissions and have a chance for our amazing panelists to answer them live. So first of all, thank you again, Dr. Dewing, Dr. Kerbel, and McLeod for being very active in the Q&A already. This is a question for Kori as well as I think Dr. Kerbel. What are some of the treatment options for the kinds of arthritis that affect the hands and the fingers? I know Dr. Kerbel, you said in the chat that you personally don't specialize in hand surgery. Are people still doing joint replacements on these tiny, tiny little finger joints?
You can. It's very dependent on which joint it is and where your current function level is and what you're trying to do. So like certain joints, like for example, the CMC joint, like right at the base of your thumb over here, you see very commonly, and that's a surgery that does amazingly well. And there's different ways to do it. There's like all these different techniques you can do. You can put, I think someone asked in the chat about putting a tendon in there. You can do like a little suture between the fingers, all different options. That surgery does amazingly well. Some of the other joints on your fingers are a little bit tougher because, as people have mentioned in the chat, some of them you can only really fuse, which means you can't really move it much, but it can be a good pain relief for some people. It's really tough with hands because it's very patient dependent and very dependent on what kind of arthritis you have. So for example, a lot of people are asking about knuckle surgery. In rheumatoid arthritis patients in particular, where they can really have, the MP joints, metacarpal phalangeal joints get affected.
Mine aren't too bad after 20 years. That's because I'm a testament to the medication.
Right. And so that's the amazing thing now, is because we have so many unbelievable biologic therapies, it's becoming less and less common, which is amazing. You talk to hand surgeons who practiced 30 years ago and they'll be like, oh, we did that all the time. And now you see it a handful of times a year, which is amazing. And so there are options. You can do replacements of these knuckles over here. Some of them are rubber, some of them are different materials. It's very dependent on your surgeon, how skilled they are, what their experience is. There's different implants, and a lot of it depends on what the surgeon's comfortable with and where you're coming from. If you're a very young, active patient who wants to, play sports, maybe not the best option to get rubber knuckle replacements. If you're sort of a bit more, and you're just trying to get back to like being able to do your daily activities and just pick something up off a shelf, can be a fantastic option. So it really depends on where you're coming from as a patient. That's why, again, I know people get frustrated, like, why do you keep saying go talk to your doctor? But so much of this depends on you as the patient. It has to be tailored to you and what you need.
Love it. Actually, I have a different one for you, Kori. Sorry, just because I'm trying to keep an eye on the time. What are some anti-inflammatory medicines that are used for osteoarthritis? If someone's not at the point where they're doing surgery, but they're looking for some inflammation control.
Yes, I honestly really do recommend the guidelines from the American College of Rheumatology and Arthritis Foundation that were published in 2019 and are available for people to look at. Those guidelines go over the management of osteoarthritis of the hands, the knees, and the hips. And why these guidelines are important is they've looked at all of the data and they've made recommendations on which of these things would be worthwhile to try. And so anti-inflammatories certainly are one category of therapies that have been used and are approved and also recommended to try. Not everybody can use anti-inflammatory medications. So it is important, if you're going to start on a medication like an anti-inflammatory, even if it's available over the counter, that you talk with your prescriber ahead of time to make sure that it's safe for you to be taking. So over the counter ones that are available would be ibuprofen or Motrin, and there's also Aleve, which is naproxen. There is also topical anti-inflammatory creams, which can be used, especially if you have one or two joints that are affected, and those would be that would be like a Voltaren gel, diclofenac gel. There are prescription anti-inflammatories that are used as well. And none of these medications really work better than others. I would say that if you have tried one and it doesn't work for you, it doesn't mean that another is not going to work. It's worthwhile trying another different form of anti-inflammatories. But Cheryl, I also want to mention that with hand OA, so important, and this I would get back to you. Your occupational therapist has a lot of interventions that can really help. And that's a very common thing that is often overlooked. So I don't know if you want to answer that, Cheryl.
Oh, yes. Yes. So occupational therapy and physical therapy are often underutilized in the multidisciplinary team, and we can really help you. My first question to a patient is, walk me through a day in your life. literally from the second that you wake up to the second you go to sleep, and actually including sleep. If you're having a hard time sleeping, which most people in pain do, where can we tweak things? Where can we integrate, either a coping skill or a adaptation, like a life hack? And so, yeah, don't forget your occupational therapist. I know the Arthritis Foundation has a podcast about occupational therapy as well. So don't forget that. Michelle, Dr. McLeod, are there non-medication alternative options for arthritis or osteoarthritis sufferers? We kind of already touched on a few of them, like exercise, but.
Yeah, I'm so glad that Kori brought up the ACR and Arthritis Foundation paper on that, because as she mentioned, for OA, actually, there are a lot of recommendations on there. I think, the number one when we think of physical activity, I think sometimes people hear the word exercise and think that you've got to be in the gym every day lifting heavy weights, or running like all out on a treadmill, and even walking is really underestimated. But I think the exercise that is unanimously recommended by ACR Arthritis Foundation for providing some relief is Tai Chi, right? So, and it's not something that we think of when we think of like exerting ourselves with physical activity, but that when thinking about activity specifically, it should be something that you enjoy doing, that you're going to continue to do, and something that's accessible. And so, maybe sometimes that means, finding a buddy to do an activity with you. And I think that there are potentially some complementary therapies that wouldn't necessarily hurt to try. I think I saw someone had mentioned, maybe in the chat or commented, trying things like acupuncture, that sort of thing. Again, those are conversations to have with your healthcare team to see if, would this be an option that I could try if it's within your means to do so. And so, I think, as I mentioned, unfortunately with OA, there's not a lot out there to support that there's, there's not a good treatment option, other than managing weight through diet and exercise and symptoms, for right now.
Yeah.
And I would say that the guidelines also recommend, it depends on the type of arthritis, but even heat and therapeutic cooling, those can be helpful. Cognitive behavioral therapy is also recommended. Certainly different types of bracing might be helpful for hand. Paraffin therapy might be helpful. And for knee and hip arthritis, using a walking stick, a cane, can help offload some of that pain. So there are different things that you can try, and I highly recommend looking at the guidelines to make sure that you've really thought about all those different things that are non-prescription.
Yeah, absolutely. And just for time, we're going to do one more question for Dr. Kerbel this time. This is an interesting one I haven't thought of. Do top athletes have different choices in treatments than the rest of us? If yes, why do we not have those options? I don't know the answer. Is there a secret?
Yeah, I don't think really. I think everybody, there are some experimental things that maybe are part of a clinical trial or insurance doesn't cover and cost a lot of money. And athletes tend to have, at least famous athletes have more money, so they can potentially try those interventions. But it's not like there's some secret society of amazing surgery that only athletes get and everyone else doesn't have available to them. They get the same surgery as everybody else. Sometimes they get stuff that's less successful or more aggressive than other people. It's just because it's kind of a different calculus with athletes. You're just trying to get them back on the field as fast as possible, not necessarily looking long-term. I think for the average person, that mindset is probably not the way to go. My goal, especially with my patients, and I think the way most people should think about it, is trying to create a long life full of high quality activity that you enjoy. So it's not just about, people say not just lifespan, but health span, sort of like having a long life that is meaningful and that is doing what you enjoy. And so with athletes, they're not thinking about that. They're thinking about, how can I play the next game next week? And you see a lot of them have really debilitated conditions afterwards because of that. I think the average person should really think about long-term solutions to get them back to doing what they love.
Beautiful, beautiful point. Well, thank you all again. I'm going to give it over to Rachel from the Arthritis Foundation. I think she wanted to, or no, I'm going to put the slide up. Never mind. Sorry. I thought I was multitasking well. One more thing to multitask. There we go. The last slide.
Hi, everybody. So the title says Rachel because I am using my colleague's
Okay, that's what I was
really.
gonna say. I was like, I must be having a stroke because I just
Yes,
thought the way
no, so no problem. I'm Asia Lee. I'm the Director of Patient Education here at the Arthritis Foundation, and I am so happy that you guys joined us. Thank you to every single person on our wonderful panel. Each of them I have a relationship with, and I'm so grateful. So shout out to you. I wanted to wrap this call out by giving you some resources that you can use. We don't want you to just come on here and learn a bunch of information, but not be able to further your journey. So one, we have an upcoming webinar every single month. The next one is clearing brain fog, stress, and fatigue. That is Thursday, June 20th. But as usual, you can always go to arthritis.org/events/webinars where you can see all of our upcoming events as well as our previous ones. We also have connect groups. We have connect groups for OA, RA, military groups. We literally have a group for everything. So come together and get some community. We also have podcasts. Cheryl's actually done one of our podcasts. So if you go into our archives, you'll see that as well. So we have tons of information for you there. We also have a helpline, and we have some bilingual staff on there that can help you at any time. And to what my colleague Michelle said, the clinical trial finder. We need people like you to help us out with this research, help us with science so that we can get more people healthy and we can finally get a cure at some point. At the end of this webinar rather, you will get a survey. Please tell us how you liked it. Tell us how we did. Tell us what information you like to see moving forward. But until next time, thank you guys.